My dear colleagues, I first want to thank Dr. Sham for his kind invitation at such a great event. I first present some French great innovation in orthopedic surgery, and then I will propose my approach of the cuff pathology based on my approach of the French experience, not the French experience. Next. Sorry. Every time here. I got some conflict of interest, like with Evolutis, I'm a consultant, and with VIMS. Innovation in orthopedics in France are numerous. For example, the hip anterior approach has commonly been used from 1947 by the Judas brothers and their sons. In hip arthroplasty, the cementless technology appeared in France in 1974 and ceramic in 1978. The double mobility concept was born also in France. Well, briefly for the history of concerning shoulder surgery, the first articular metal prosthesis ever implanted in the world was the shoulder, and it was in France. It was made of platinum and rubber, and it has been implanted in France in 1893 by Professor Péon. Since this first achievement, many surgeons all over the world have contributed to the development of the shoulder anatomic prosthesis. The most famous is obviously Professor Charles Neer, who invented the first modern TSA back in the 50s. But the third generation total shoulder arthroplasty was achieved by Dr. Walsh and Professor Boileau in 1995, and it had a worldwide spreading after. Just the French activity today. In 2018, the large majority of shoulder surgery concerned the rotator cuff, and representing 74% of all shoulders procedures, of which 35 were tendon repair, 23 were intervention on the long head of biceps, and 41 were acromioplasty. In fact, the figure of the long head of the biceps is very underestimated. The anterior posterior instability represented 6% of all procedures, with an important proportion of bone procedure, LATAG, and only 7% of all the procedures were joint replacement. An interesting forecast was performed by my colleagues recently. This study shows the constant increasing number of shoulder procedures between 2012 and 2018, with more than 24% increase. But there are different scenarios that have been forecasting, and many taking into account the changes in the French population number, in age and number, and also in the increased prevalence of these procedures. So it can lead to an augmentation, an increase of up to 300% of the number of procedures in France during the next decades. Well, there are still significant differences between metropolitan territory and overseas territories, but everywhere the majority of the shoulder procedures are performed in private institutions, I think just like here. And this tendency is expected to increase in the coming years. Well, shoulder surgery does progress because it's a relatively new type of surgery that had benefited from many new and recent innovations. The most spectacular innovation, recent advance in the treatment of previously untreatable rotator cuff tears is obviously the reverse TSA, when it has been invented in France by Professor Gramont in 1986 in the small French town of Dijon. And in 1991 appeared the first efficient modular metallic evolution, the Delta, that everybody knows now. And then the reverse spread quickly from France to Europe and to the rest of the world. The American had to wait more than 10 years to have a FDA approval, and the first reverse shoulders have been implanted in 2012 in India, and it was with a French company. So, when an operative treatment of a cuff tear has been decided, there are still some technical options that can lead to controversy. I'm talking about simple cases. First, until what age may I propose a repair? What should I do with the long head of the biceps? Do I perform an acromoplasty always, not always? What about adding distal clavicle resection? What is the place of the reverse? And what about the future? First of all, primum non nocere. That's a Latin phrase which said, do no harm. We have to remember that 20% of the people in their 60s have asymptomatic full tear. Then the rate of healing of the repaired cuff is falling from 92 to 40%. If you take into account the age, like Boileau said, the size of the tear, the tendon retraction, and the anterior rotator cuff failure. And there is still a middle correlation between anatomic lesions, symptoms, and physical tests. And what about the time of evolution? A painful shoulder at 2 months may be asymptomatic at 6 months. It happens. For example, here an example of one of my patients, 60-year-old, karateka, with a massive unrepairable tear. And it was painful during 3 months when he came to me with an arthro-CT scan showing this huge unrepairable tear, except maybe for the subscap. And well, he was able to, oh, can you send them the movie? Can you send the movie? Just to see what a guy with this type of injury can have. Yeah. Okay, this is, so who would dare to repair, for example, the subscap or do something more with these patients? Well, this guy had a spontaneous long head biceps rupture. So let's talk about the French biceps killing concept. So the long head of the biceps seems to play an important role in the genesis of the symptoms, particularly the pain. Our famous colleague Jill Walsh described here a series of biceps tenotomy with a long follow-up without any cuff repair. You see the results were quite good, with 87% of people, the patients satisfied at 5 years. Nevertheless, the arthritis rate increased from 38 to 67%. But we can see that the acromial humeral distance decreased only for 1.3 millimeter. And acromoplasty seemed to increase a little bit some kind of the patient. So if the biceps tenotomy can lead to good results for many people, non-demanding people or all people, is there especially for other people, are there, and this theoretically without any limit of age, is it possible to have better results in this type of patients if you repair? Well, is there a clear age limit for repairing a cuff? For example, no, this is still in debate. For example, this work represented by the French Arthroscopy Society showed that repair is maybe better than simple decompression and tenotomy of the long head of the bicep, and that even after 75 years old. So what about the acromoplasty? Is it necessary? Well, it showed that it has a low heterogeneity for sure, but if you see the systematic review of all the series, one of the conclusion was it cannot present an impressive effect, so there is no real proof of its relevance mechanically nor biologically. It allows, I think, a better exposure for me. Sometimes it helps me positioning the portals, so I do it all the time. And when I see a fraying coraco acromial biceps tendon, well, I think there is an impingement, and I do also a bony acromoplasty. Furthermore, what to think of the adding a distal clavicle resection complementary to the tendon repair or an acromoplasty? We have to remember that AC joint osteoarthritis remain asymptomatic at long distance, and there is a recent survey from the French Society of Arthroscopy, which studied the benefits of distal clavicle resection, and it concluded that it leads to worse results, and especially if the resection was superior to 11 millimeters. So what do I do when I do what's my point of view on rotator cuff repairable tears? Well, I always do double to triple rows. I want to have the maximum pressure on the footprint and to lessen the tension on each stitches. I'll always do a tenotomy or a tenodesis in younger patients. And I'm acromoplasty quite always also. And I discuss sometimes the distal clavicle resection. So what about the tendon repairs? Well, treating a rotator cuff tear means mainly dealing with aging tissues. So are we able, thanks to our surgery, to slow down the impact of time? Well, not impressively, as shown in these two French studies, which analyzes 20 years after the healing 20 years after rotator cuff. Osteoarthritis rates are quite high at 20 years, and the retear rate was about 40%. Nevertheless, the rate of need to do a reverse is very low. So maybe it means that the role of the tenotomy of the biceps still is useful. So what can we do at the end of the story of the aging cuff? The RSA is the ultimate weapon when we have to deal surgically with an important glenohumeral osteoarthritis associated with the cuff tear or with an irreparable cuff, especially when there is no more long head of the biceps in the joint for me. Well, I have chosen to do it through a superior lateral approach for its advantages, which is the exposure of the glenoid, less subscap and posterior cuff arm or tear, and less dislocations. What will be the future? Well, as we have seen, the complete healing of a cuff leads to very frequently to be best possible when to best results. So since you're like some of us, I've tried to add some iterative repairs, the different biological scaffold available in the French markets, the fasciolata, the Arthrex, mainly the Tornier, the Regenet. And as a matter of fact, for me, there's too few to conclude at this time for their effectiveness and reliability. As said just Stephen Snyder, he said, well, the field of tissue engineering will certainly be part of our rotator cuff surgical future. And I thank you for your attention. And I invite you to France whenever you want.
Thank you, Dr. John. We can take a couple of questions. Any specific queries? Yeah, please join us. For all speakers, any questions from the delegates? If you don't ask, I'm going to ask you a few questions. Delegates, now who will define what is irreparable cuff tear? Anybody? There were 7 lectures, now you should be able to answer this. What is irreparable cuff tear? Karthik, can you answer?
Irreparable cuff tears are cuff tears that after we do adequate release, we try to mobilize, we medialize the footprint, still we are not able to repair. Despite all that, then we term it as an irreparable rotator cuff.
That's true. Then tell me second question, what is pseudoparalysis?
Pseudoparalysis
Definition.
Is a condition where patient is not able to do active forward flexion or abduction in the, but the passive abduction or forward flexion is intact in the absence of neurological deficit.
Okay. So passive range of movement is full, but active forward flexion less than 90
90.
is called pseudoparalysis. Any questions?
Sir, I have one question.
Yeah.
So when a patient is around 50 years of age and is having a pseudoparalysis with an external rotation lag, so what will you decide in that situation? He is having external rotation lag also and pseudoparalysis also.
Yeah, so I think a very relevant question. So I think age of the patient, chronicity of the symptoms, at the same time demands of the patient will decide the option of treatment. Now you have to see the pattern. Now he is 50-year-old. If it is a chronic disease, see, pseudoparalysis sometimes reverses within couple of weeks if it is just due to pain. If it does not improve beyond 2 or 3 months, then it's the real pseudoparalysis. In that case, you will have to define why this is happening, the pattern of cuff tear. Now we have seen this, what Mahesh shown, Collins classification. So whether it is antero-superior, superior, or posterior-superior, or global. Okay, so from the history what you are telling me, abduction and external rotation both are weak. That means supra-infra and probably even teres minor is affected. Now it is very important to assess. At 50, we are not going to think in terms of replacement. So we are going to think in terms of soft tissue procedure, necessarily probably tendon transfer or something like SCR. Now prerequisite for any procedure is you have to have intact subscapularis or repairable subscapularis. So if you have good subscap, if it is only abduction, good teres minor, then probably SCR will work well. Or if you have abduction and external rotation both weak, of course you would do MRI everything to confirm, then probably lower trapezius transfer or LD can be a good option. Okay, so you have to look at all aspect, abduction, external rotation, and then individualized treatment for that particular patient.
Thank you.
Any question before I summarize? Yes.
So I have a question to Clement, sir.
Yeah, Clement.
So you told superior capsular reconstruction with long head of biceps. So first you will put the long head of biceps using an anchor, and the tendon you will put supraspinatus over that. Won't it cause overstuffing of the subacromial space, or do you do a decompression acromioplasty for all patients when you go for that, sir?
You know, sometimes we do a subacromial decompression also, but not routinely, unless preoperatively they have severe pain and crepitus. It may not lead to overstuffing because the cuff also will be very thinned out most of the cases in this age group. And it is something similar to a spacer effect, the balloon what you are injecting in nowadays, the subacromial balloon spacer. So this tissue will act like a balloon spacer. And once you establish the superior capsule restraint, the head of humerus is going to be depressed. The moment the deltoid is working, it is not going to go up, it is going to come down only. So that's how it helps in your elevation also. Actually, you will be opening up the subacromial space by this one. Yeah.
Okay. So none of your patients post-operatively had symptoms of impingement?
No, no, no.
Okay, thank you, sir.
Right.
So I have one more question, sir, to Ayyappan,
please.
sir. So sir, you told superior capsular reconstruction fascial lata, and you mentioned something about thickness. Is there any, means we have to double it or triple it? Any thickness, any means it should be 5 millimeter or 6 millimeter, anything like that, sir?
I had actually mentioned it is 8 millimeters.
8
so
millimeters,
Dr. Mihat has done studies. In the studies, they are compared 4 millimeter, 8 millimeter. So 8 millimeter is a cutoff. So
Okay.
now we can double it or triple it the way we want. Sometimes in older patients, we find that it is much thinner. Then we can triple it.
Okay.
So 8 millimeter is the ideal. That means thicker is ideal because it acts as a spacer effect.
A space. So same doubt I had, when if it is more thickened, will it cause any impingement, and that's what?
No, okay, because see, impinge, so one minimal acromioplasty is required. So when you look at papers complaining should in a CR, should you do acromioplasty or not, is there. So when you do an acromioplasty, minimal not too much. If you take too much of acromion, okay, it causes proximal migration. So minimal acromioplasty to remove the spurs as required. And after that, you prepare initially. Nothing happens. It doesn't impinge as such.
Okay, thank you, sir.
Okay, yes.
That's a question to Dr. Martin. I was just interesting to see the data that showed about only 6% were instability surgery. In that about 100 patients, you had 6% was instability surgery and 43% were subacromial surgery. It was interesting to know what surgery they were all.
In France? Why? Aging patient population probably, so.
They were like bursectomy, that kind of surgery, or what?
6% of the procedure in France are done for instability. That means probably because if it's less than in India, it's probably because the mean age of the population is higher in France than in India. I just see this as an explanation.
No, it is very surprising to see only 6% were instability surgery. So I think we all do a lot of bank cards and all. They don't come under that category.
That's 6% of the total of the procedure
out
in
of
France.
100 surgeries, you said 6% were instability surgery.
No. They're all together.
Okay.
And the rate is about 53% for Latarjet. There is more Latarjet than Bancard done in France, and more and more. This will occur more and more.
Any questions? So to add few points in addition to this, which we could not probably cover in the discussion, is there is definite role of conservative treatment also with irreparable cuff tears. Elderly population can be put on a good rehab program where there have been papers of anterior deltoid training, which gives better results and improvement in the functional scores. So that is something you can read about Philip Moroder's paper on shoulder pacemaker. So he has done a lot of work on that. Secondly, when you are tackling irreparable cuff tear in elderly, it is very important to understand the grade of arthritis, as it was mentioned in one of the lectures. If it is Hamada 3 or more, where acetabularization of acromion has started happening, or arthritis takes into place, then there is no role of any soft tissue procedure. You will have to think in a term of replacement surgery. Now, when you do replacement surgery, it depends whether you want to add any tendon transfer depending on the external rotation weakness. If there is significant external rotation weakness, then the reverse shoulder replacement will not give you external rotation movement. It will just give you forward flexion. So you may have to add latissimus dorsi or L episcope, where you do teres major transfer as well to give a external rotation. And I think there is some role of partial repairs also in elderly population, where you can try to restore the force couple by advancing or repairing subscap in the front and repairing whatever partial infraspinatus teres minor is still there. You can repair it back and it gives reasonably good function. But the only downside is the short term it works well. In long term the results deteriorate. So probably it is a good option in an elderly patient. And of course in younger patient you have a different option. Whatever you are skilled at, you can definitely offer after proper counseling of the patient and understanding his or her demands. Two important things, as I mentioned, you have to look for subscapularis integrity before you offer any tender transfer. It is very important to even look at the teres minor. I think Hornblower sign testing is very important. If you have good hypertrophy teres minor, then all this procedure, SCR, lower trapezius transfers, are going to work better. If you don't have them, then results are bound to worsen. That's it. I think that's, I would summarize. Anything to add, or we will call it a end of the session? Okay. Thank you all faculty for excellent presentations.
Thanks, Rish. That's what I expected from you, and you summarized very well. Thank you. So over to Dr. Santosh Sanan, who will moderate the next session of Introduction to Tensor Trans-Os Tunneler.
So the last interesting live surgery before we go live with Dr. Shyam about transosseous suture repairs of cuff, which we believe has a lot of future, and it's not discussed in detail in most of the places. So that before we go live with the product and the surgery, we would be joined by the team which has developed this particular transosseous tunneler, which is by Tunia. The team includes their designer and the primary surgeon. They're there live. We are watching you live. Let's check the audio, Justin and Dr. Brett Sanders.
Yes, good afternoon.
Good afternoon
hear me?
for us, and I guess it's
Hi,
in the middle of
everybody.
night. And sorry to keep you awake so late. You look fresh. You must have had a nap and woke up again, I guess.
Well, it's 3:31 a.m. here in Las Vegas.
Thanks a lot.
So I feel fantastic. Thanks for letting us join you. I'm here with my great friend and colleague, Dr. Brett Sanders, who's in Chattanooga, Tennessee right now. If you wouldn't mind allowing me to share my screen, that'd be fantastic.
Screen chat, please. You can
disabled.
start sharing your screen now.
It says host disabled participant screen sharing.
Hold on. Try now, Justin.
There we go. All right. Let's see here. 1 second. Let's try
Yep.
this. You see? Yeah. Fantastic. So let me pull up. All right. Can you see this?
Yep.
Fantastic. Well, again, my name is Justin Anderson. I'm the president and CEO of Tensor Surgical. I'm joined again with Dr. Brett Sanders. We're going to talk to you today about a system that we've developed here and are launched globally. It's been commercialized for a number of years now. We've just refined it and made it better in working together. Again, thank you for allowing us to participate remotely here. I want to start off by giving a special thanks and honor and gratitude to this fine young man, Dr. Krishnan Senior. I call him Big Boss. A lot of people don't know because he's so humble that he, even though he's retired, behind the scenes makes things like this possible, bearing personal expense and time to get these devices in the hands of surgeons like Dr. Sandar and others, and make them available to the great country of India and those that are less fortunate. So thank you, Dr. Krishnan, sir. We really appreciate it, and we know that you've done a lot of work here. I also want to thank Dr. Rajan for allowing us to participate in your STEAM course. We look forward to visiting you in person at some point. Also, Dr. Sandar, thank you for doing this live surgery that we're going to lead you into today. And a lot of it happens very, very quickly, so I wanted to set this up for him so you understood a little bit more about what's happening during those steps. And I also wanted to take just a second and thank my great friend, as the best man in his wedding, Dr. Krishnan. People forget sometimes about history and evolution, and there's always someone who started something. And Dr. Butch Krishnan was the one who stuck his neck out first and developed the first device, the Ortho-Tunneler, which I acquired from Tag Medical and commercialized with Tournier, which was the first mover in the space. And that led to the Dr. Sanders and others getting into it, but it wouldn't be possible without this person's insight, and we're taking the ball and running with it and adding all of our years of experience to making a next-gen product, which we've done here. I want to thank Dr. Sanders himself. This man works tirelessly. He's just a brilliant surgeon. It's really exciting to work with someone who has a physics mind and engineering mind, background, and have the talent and the pedigree that he has. So there's no reason, it's not hard to believe why Tensor is going to be such a success when we've paired together. It's magical. We also have founded and developed a new device that we're going to be, we have several patents worldwide, and in fact we have patents pending in India, so we hope to be bringing this to all of you soon. So this has been a journey that's evolved over a period of time. I told you that I worked on developing and commercializing the very first mover in the space, which was the Ortho-Tunneler. This started in 2005, 2006. And as you see on the left, there's an evolution of these type of devices. A lot of companies have tried it in the space and they didn't make it. And here we are. If you haven't read this article yet, it's new. It's a review article in the Journal of American Academy of Orthopedic Surgeons, April 2023. And this is the first article in the space on arthroscopic transosseous cup repair to this degree in a peer-reviewed journal. So I encourage all of you to read it. It really does a great job summing everything up. I also want to point out, in my opinion, I propose that there's a lot of talk about transosseous equivalent over these years, and transosseous equivalent, in my professional opinion, is really a marketing term that people have bought into a number of reasons. But just like we don't talk about gout equivalent or arthrosis equivalent, it's pseudo-gout and pseudo-arthrosis. And transosseous equivalent isn't transosseous, as you see here. It's a pseudo-transosseous, trying to mimic the effects of it. But as you can see here, it's not quite that. So I think we should be calling it really what it is. So what is the transosseous tunneler system? It's a reusable instrument set that's well positioned for value-based care. It has 2 reusable instruments there, as you see. The reusable set can be broken down into 5 individual components for cleaning and sterilization. There's some disposable components to it. This is the disposable all inserter, and I want to stress the importance that this is a single patient use device. It can be used many times in the same patient, biceps tenodesis, ankylosing, the cuff, etc. But it is a disposable device. It's not to be reprocessed or reused. We do not drill through the bone. It's a self-punching device, so that we want to keep that the tip sharp so it doesn't break off in a patient. So I know people have talked about it, but that's something that just isn't going to be a factor going forward. It's a single patient use and needs to be disposed. We have disposable suture and suture tape. High strength, we have a specific suture that loads on that all inserter. It's made to work with it. And we're the only company in orthopedics that has 3 different colored suture tapes, all in the same sterile pack, designed specifically for transosseous repairs. So when we first came out with these transosseous devices, all we had was size 2 suture. And the common concern with everyone is, what about osteoporotic bone, soft bone? That is a very viable concern, just like in soft bone about an anchor pulling out. However, suture tapes has changed the game for transosseous repairs and made this suture cutting through bone pretty much a once, in the words of Mark Lazarus at Rothman, a once every other year phenomenon, even in the most osteoporotic patient. So what do they do when they get into the case? They have the device, they put it together. You see this anvil up on the top. You just pull that back into a cocked position. We have that all inserter that's disposable. We take the size 2 suture on that, load it into a slot on the very distal end, and secure the tails, both of those tails, into the slot under tension. So then we take the all inserter with the suture loaded on it and insert it into the proximal end until it snaps into place so it doesn't fall out. And that's what it looks like on the back table, ready to use for the surgeon to go. You've got it's cocked with that anvil back. You've got the all inserter in there so it doesn't fall out. And here we go. We take a medial awl, as we call it, a bone punch. No different than you put in a medial row anchor at the adjacent or juxtaposition of the articular cartilage where the bone is nice and hard. And we're going to establish a portal with a spinal needle, and we're going to come in. This is very, very important, is a spinal needle coming in exactly right on the plane of the footprint. Not too high, right on the plane of the footprint. And we'll pull it out, and right where that little drop of blood is, we'll go down about 7 to 8 millimeters, make an incision, and pop that right through the subdilated fascia, and we'll put the tip of it right into the medial tunnel you created. We'll release that lever there, and we're going to insert that with a mallet. There's no drilling or power required with this device. It's the only one of its kind like that. So we take a mallet, bottom it out, and what you see there in the circle is that all inserter is advancing forward and driving through these nitinol tines and catching the suture. You release the suture strands from the slot there, remove that all inserter. If you look down the lower left, it's left with the suture caught passively inside those nitinol tines. No flipping between levers or anything. Just insert it, pull the inserter out, and it's caught. Then you lift the tunneler out of the bone. That pulls a loop out, and that's your shuttle. Then you just load your suture tapes that we have through that loop and shuttle them through the bone. Then it's standard cuff repair at that point. Pass your sutures, tie your sutures, cut your sutures. So this is a video here I'd like to play. And Dr. Sanders, if you would mind narrating this for us. This is a first-person point of view video of you in the OR. And this is going to tee Dr. Sundar nicely up in the OR to take a different view of what you're about to see live, also in beast chair position. So Dr. Sanders, if you wouldn't mind, give us your insight here.
Thanks, Justin. And thanks, everybody, for attending and for your interest in our work here that we've been working on for about 12 years now. Here we're coming in from the superior medial portal, and you can see up the screen superiorly. We're going to assess the footprint, and I keep the all in for efficiency and plan the footprint so we make all the holes at the same time. Instead of coming back and putting one anchor at a time, you can actually plan your footprint perfectly and place your medial holes where you want the cables to be. So I try to reconstruct the superior capsule from inside and put the cables back precisely where they want to be. And you can do this with these small diameter tunnels. Obviously, these are bone marrow vents. This has been linked with healing. And we use the awl, it's a variable diameter awl, and we can use it to make a microfracture too. So I usually make a little microfracture there laterally. We decorticate a little bit laterally. I leave the bone medially, and I tend to leave footprint medially too. That's been shown from Japan to reestablish, the fibers, Sharpie's fibers better. My video is a little jerky here, but it looks like we're going to come in with a tunneler here pretty soon. Okay, there we go. We're cleaning out the bursa here. And I don't do this as much anymore. I just go ahead for speed and just find it later. But in the beginning, you're probably going to want to clean out the bursa. And I use an arm positioner to keep it in forward flexion. Now we're going to pop through the subdeltoid fascia here, rotate up. We're placing it in an inverted fashion, and then we find our medial awl, translate inferiorly, and then rotate. And that gives you the biggest bone bridge. And then the assistant can go ahead and drive the awl in. There's no drilling or removal of bone. That strengthens the lateral tunnel. This is a 1.4 millimeter small hole. And then we pull our suture through, and it happens very quickly. I prefer to manage the suture, the pull-through suture through the superior medial portal first, and that naturally separates the sutures for management. And then we pull through our triplet. The triplet is the functional moiety of transosseous surgery. It's a good balance of speed and strength. You could put 5 or 6 sutures in there if you wish, and that'll become stronger than anchors at some point. As you know from previous studies all over orthopedics, it's about the number of sutures crossing the repair site. So there we go. So there's our first tunnel, and we use colored suture clips to manage them topographically. So the anterior sutures on the drapes are anterior in the patient, and so forth. So here's our next tunnel coming in through the same portal. Inverted introduction, and then we bring it in, rotate. And I will usually internally rotate the arm here to create a large bone bridge in the AP direction. And that distance that's a very strong mattress suture because of the anisotrophic properties of bone. That one almost would never, I'd be very surprised if that ever cut through. You can see how stable it is. I can actually let go with my hand and reposition it. So it's very easy. Delivering the suture is the easiest part of the case. The learning curve is suture management, really. And then in this case, we're gonna put another triplet. And I was using off-the-shelf commercial sutures here at the time. And this is gonna be a true transosseous hybrid repair. So you see very quickly, we've got the equivalent of 4 anchors. And this is where you pick up time on the transosseous technique. You're gonna pass simple sutures. And then when you make a tunnel, it's like putting 2 anchors in. So it's more efficient biomechanically. And no one talks about that, but that's why it's time equivalent in independent studies. Here we're seeing the biology, the totipotent stem cells elaborating from the tunnels. And this is why they have less pain and better healing. That's been shown in a randomized controlled trial out of Italy. Level 1 study showing less pain. So here's the here's the results of the hybrid technique with 5 fixation points. So the fixation point density per surface area is much higher. It's like a bed of nails rather than 2 nails, which would penetrate the tendon. So it will decrease the force per unit area. So it's very strong, very natural reproduction of double row footprint with a much higher value ratio, outcome over cost, much higher fixation point per cost, less pain, and better revision because we don't get the type 2 failures that are anchor induced that cause catastrophic failures and SCRs to revise them.
Thank you very much, Dr. Brett Sanders and Mr. Justin Anderson. There's an elegant demonstration of your technique. Hopefully, Sham is going to be doing the tunnel technique for the next case. However, let me ask the audience, do you have any doubt, anything they want to ask you? Yes, Chansaya. Dr. Chansaya from Hyderabad.
Hi, Dr. Sanders. How do you pass the switches? Do you pass in a simple configuration or a mattress fashion? How do you pass the switches and how do you tie the knots?
So for me, it depends on the exact tear geometry. I personally don't do it the same way every time. I have special techniques for certain tear patterns. And you can go as simple or as complex as you wish. So you can make crossing sutures, an X box that Krishnan calls it, or the true transosseous hybrid that you just saw. In the beginning, I recommend starting with simple sutures. So it's like a crow's foot. It looks like that for 2 tunnels, just simple sutures, and it's very effective. The next most complex would be a box, a mattress suture with 2 simples. I believe that's what Sumant Krishnan does usually. For large tears, I do 3 tunnels, and I create a double box. But the more complex and the bigger the tear, the more likely I am to do just simple sutures. And we incorporate the biceps, the subscap, and again, all techniques that you do currently with anchors, like SCR or tendon transfers or biceps tenodesis, we have techniques to do all of those transosseously. And when you use simple sutures, the time actually becomes very fast.
Thank you.
Thank you. Any other questions, anybody? Dr. Subramanian from Madurai.
Hi, good afternoon, Dr. Subramanian from Madurai. What is your view on osteoporotic bones? Which technique would you prefer?
I think
In
the question was about osteoporotic bone.
Yeah, osteoporotic bone. You think
Okay,
this one is
so-
better or anchor method is better? Which would you prefer?
So I got this question a lot, and this is why I developed the true transosseous hybrid technique, which you can look up in arthroscopy techniques. It's a hybrid. But I've I had a lot of surgeons ask me about suture cut through, and then they would call us to use the tunneler for a bone cyst or for a massive bone defect. So they were concerned about bone cutout, but then they wanted to use it in the absolute worst bone. So I started to think, well, is it a problem or is it the solution? And now I actually believe, especially with the true transosseous hybrid, that transosseous tunnels are better for osteoporotic bone because of the lack of complications of anchor pullouts, anchor voids, and hardware blowouts. You know, when you put an anchor in soft bone and it pulls out, it makes it worse. It goes from bad to worse. So especially with medial bone loss, you can have a complete loss medially and tunnel through it and just proceed as normal. And if the bone laterally is intact, that's a solution right there. If the whole bone is soft, what you do is put sutures in transosseously to reproduce the normal vector that you normally would with a double row transosseous repair. And then the whole construct gets backed up down in the metadiaphysis where the bone becomes hard again. That's the true transosseous hybrid. So that's the solution, is to put less hardware into the bad bone, not more. It's like a principle from trauma. You stay out of the zone of injury. You work around the zone of injury. You don't put more hardware in the zone of injury in a pathologic bone. We also deal with this by not drilling, and by a rectangular geometry of the punch creates, and it compacts the tunnel, so it theoretically strengthens the tunnel. And also using tapes, and also using high density of suture. So the more suture you put in, the more the forces are reduced per suture. So there's a lot of factors going on here in this next level sort of techniques that we're doing. There's been a lot of changes that address this. Simultaneously, I'll mention two clinical factors. One is we're repairing younger patients with smaller tears, so the bone is harder because we have documentation that tears progress. But the biggest factor has been what Dr. Martin talked about, the reverse. Now that the reverse is here, the horrible osteoporotic bone patients that are 80 years old, they get a reverse now. So osteoporosis starts around 74. So there's a ton of cuffs between 40 and 75, let's say, that can be repaired, and it's just not really an issue.
Hi, I have a question. While putting
Yeah, the last two questions, I think, Prashant and, okay.
Yeah.
Right.
Okay.
Prashant.
While putting the tunnels, what is the safe distance, like without risking a tunnel confluence or a GT fracture, what is the safe cutoff limit or the minimal or the maximal distance where you advise to put the tunnel as close as possible? So is there any cutoff?
Yes, good question. We recommend, or I shoot for a 1 centimeter. I try to put a fixation point every linear centimeter. So I think rows is an outdated concept from anchors, from being in the box with anchors, you know. Every tunnel is a double row. What I prefer to talk about is fixation point density. So I want 1 fixation point per linear centimeter along the AP direction. If your tunnels are confluent medially, there's zero problem with that. It doesn't matter. It could be a bone trough. That's the way they used to do it, you know? And Lazarus taught me this. It really doesn't matter. They can be confluent, they can break through medially. As long as they're separate laterally, you're fine. And you can rotate the arm and shoot for about 1 centimeter there.
Okay, thank you.
And the last question, then we'll let you go to sleep.
Yeah, I'm Dr. Sujit from Cochin. My question is about the entry hole you make in the top of the greater tuberosity. When you insert an anchor, you have the option of going around 70 degrees to reach the osteocartilaginous junction. But I use the arthro tunneler or the KR tunneler, which is a look-alike of the arthro tunneler. So how do you compare the angle of entry? Because in that case, I always have to make a entry drill hole much lateral to the osteocartilaginous junction. Even in the case you showed, the distance between the two holes which were made by the tensor tunneler were not that different, not that large, just like in a double row rotator cuff repair. just a medial anchor and the lateral row anchor. Hope you get my question. So are there any techniques you do, or can you bend the tip of the tensor tunneler? But I think it wouldn't work that way, would it?
So I think there's a couple of questions there. I'm not familiar with the device that you referenced, but I put the medial awl in exactly like I would an anchor, so there's no difference. And if there's a high angle, like a high critical shoulder angle, and it's hard to get in, you can make the point hit the bone and then rotate it, and then go down. Okay, and so you can, it brings the humeral head out.
All right, while making the drill hole.
And then the tunneler, one of the advantages of our device, as it's reusable, you cannot bend it. It's very robust. It almost never misses. I mean, it's very accurate, very usable, and very fast. It produces about an 18 millimeter bone bridge, which is sufficient. And to get a biggest bone bridge possible, you rotate down, and that will give you the straight shot, and that increases the distance between the medial and lateral holes. And what I'm telling you from a design perspective is that reproducibility is going to be much more important for you in your cases, and having good outcomes and fast cases than any. I mean, we've optimized that, I think, to the degree possible. The bigger and bigger you get, it gets harder and harder to make a device that'll fit in the shoulder.
Dr. Sanders, if I may chime in for a second, this is an important point. And again, I'm not knocking the Ortho-Tunneler. I acquired it and commercialized it. Dr. Krishnan or Butch did my shoulder with it, and I have a perfect result. But it was a Gen 1 device. So in working with Brett, we made up for the shortcomings of that device, right, in this next gen, and reproducibility is very, very key. Since you mentioned the Ortho-Tunneler, and if you've used that or a similar version of it, you'll know that device is much more flexible. You have to drill or punch medially, you deploy a loop, you drill through the loop, there's no punch, you drill through the loop, you have to pull the loop back to make sure you capture the drill, pull it out, put the suture inserter in stick, pull it back to make sure you capture that, and pull the suture out. But next time you look at the device, look at the suture inserter, and look at the drill, and with your finger you can just move and you'll see how flexible it is. When the loop deploys in the bone, if you rotate your hand out of that plane, that's why sometimes it will miss that loop, because it has to be dead nuts on. So when you have a device that you want to be able to capture and really torque on it without it bending, so it captures every time, that's what we've developed. And it's very important to have it really, really robust, drive it in, passively capture it with no other mechanisms or loops, and pull it out and retrieve it. And that's the real next gen advantage of it.
Thanks for the tip. Thank you, Brett and Justin, for joining us in spite that it's very inconvenient time for you. And hope you get some sleep. Thank you very much.
Thank you.
I hope you can hear the clapping.
Thank you very much.
Right. Thank you. We'll get on to the next last surgery.
Yeah. So we'll go live